Hello, this is the sheriff's item, which is a contract amendment with NAPCare.
Brad, are you on? Can you hear us?
I can hear you. Can you hear me?
Yeah, yes.
You want me to start, or am I waiting for anything?
You could go ahead. I thought maybe the sheriff's office was getting introduced the item, but go ahead.
Great. Well, I really appreciate the opportunity to meet all of you virtually. We have a short presentation. I have with me Suzanne Moore, our Chief Operating Officer, and Amber Simpler, who's our Chief Psychologist, to talk to you about our clinical operations as well as the mental health operations at the jail facility. We have a slide presentation if there's a way to pull it up. I don't know how we can do that.
This is Atlas Pearson, Deputy Clerk of the Board. Was this PowerPoint provided to Clerk of the Board in advance of the meeting?
It was. It was attached to the agenda, so you had it in advance.
I can share it as well. I don't know if you all can see what I have on the screen, so yeah, I'm happy to share, or if you all would like to.
We're seeing your screen, yes.
Perfect. Okay, we can proceed with that then.
Chair?
Yes, Supervisor Williams?
Yeah, so previously I believe this item was on the consent calendar and board direction was for the sheriff/jail staff to provide a written report of how the contract has gone to date, and the same from our behavioral health. I don't see either of those attached. I'm curious, does this presentation, does this represent the sheriff or the sheriff and behavioral health? Or is this just NAFCare? Who is this on behalf of, what we're about to see?
Through the chair, if I might speak under Sheriff Brewster.
Yeah.
This is through the sheriff's office to bring to you the work product of NAFCare, so the board can understand the duties and responsibilities and the data of what they've done through the year.
Got it. I appreciate that. And does this also represent behavioral health, or will that be separate?
I cannot speak to that.
Yeah, I can pipe up and speak to that. And I'm Brad McLean, CEO of NAFCare. And we will give you just a quick overview. We have about 5 slides to cover that will cover mental health, including the jail-based competency services that we're providing.
Yeah, I appreciate that. That sounds great. I just want to be clear, from our Dr. Miller's perspective, does this also represent her department's take on the contract?
Supervisor Williams, this is Dr. Janine Miller, Behavioral Health Director. And no, because this is not our contract, and this is solely NAFCare and the Sheriff's Office, this is their contract. I'm happy to provide what we know from behavioral health and any information we have from what we've worked with NAFCare on, but we really don't have any oversight of their contract from the mental health side.
Okay, proceed with the presentation. Thanks.
Excellent. Well, again, we appreciate the opportunity to be with all of you today. As you're aware, NAFCare won a competitive bid process back in 2017 to provide correctional health care services at your facility. We have had a great 4-year partnership with the Mendocino County Sheriff's Department. We're proud of the accomplishments that we've made together and wanted to just give you a very brief overview of what we've accomplished in that time. We are very much interested in continuing that partnership. We appreciate your consideration of the proposal to renew the contract for an additional year. At NAFCare, our mission is to improve and save lives in corrections through innovation and excellence. And the only way we can achieve that mission is through partnerships with our local government partners. So we have really valued that partnership. We appreciate the contributions you've made to helping us achieve our mission in Mendocino County. With that, I'll ask Suzanne Moore to speak more to some of the accomplishments that we've achieved at your facility.
Thanks, Brad. Thanks, everyone. I'm Suzanne Moore, Chief Operating Officer for NAFCare, and have on the slide in front of you quite a number of statistics. I know it's rather a busy slide. These statistics represent just under a year of data, so January through November of 2021. And it really just outlines some of the ways that we provide care in your facility. So as Brad said, we've been in place since 2017. In early 2020, we achieved the initial NCCHC accreditation. And then over the course of this last year, we've, as you can see, performed a great deal of on-site care. The goal of that always being to try to decrease as much need for off-site care as possible. So I think one of the more telling statistics are the number of detox screenings we've completed over the last 11 months, over 7,000 detox screenings, which is very important to catch those patients who may be high risk for withdrawal or potentially bad outcomes. We've had over 2,000 mental health professional encounters with patients, over 687 medical provider encounters, and I won't go through all of these, but as you can see, a very high number of total medications administered. And then, all of that represents the on-site care that is provided by the team of healthcare professionals there on site. In addition to that, in the left-hand corner, you'll see Stat Care, which is a service that we do not charge Mendocino County for at all. That's an additional service that we provide that is 24/7 corporate support provided by nurse practitioners licensed in California. So these nurse practitioners are really monitoring the patients and the care. They're starting initial medications when those need to be started very urgently. They're verifying medications and just providing a great deal of quality assurance support at no extra charge that we just think is very important to making sure the patients are cared for and nothing falls through the cracks. Going to our next slide, we wanted to share a little bit about our success with COVID-19, which has truly been a collaborative effort with the staff, all of your staff there at the facility, the sheriff's office staff, and our staff working together in what has been a really difficult, last couple of years with the pandemic. We're excited that we've made some good strides in vaccinating the population. It's difficult to have the patients long enough to get them fully vaccinated, but we are certainly trying to at least get them that first shot while they're in the facility before they move into the community, and we've been really successful with that. We've even been successful with using some of the vaccines that were going to expire due to a refrigerator being broken down to be able to give those to sheriff staff as well. So we really have tried to just pitch in wherever we can and help and be of service during this pandemic. With regard to mental health, I would like to introduce Dr. Simpler, who is really in charge of our jail-based restoration to competency programs and our mental health departments.
Thank you, Suzanne, and I appreciate the opportunity to speak with you all today about our efforts for mental health services within the Mendocino County Jail. I think one important thing to kind of put up front is what mental health care must look like in a jail setting. We often parallel it to an ER visit. It has to be identifying crises, responding emergently, and really stabilizing individuals as they're walking through the door. And we do that through a collective process of screening at the point of walking into the facility. We're always looking for a risk of harm to self, risk of harm to others, and who needs to stabilize on medications quickly. What we know is that about 1/3 of the population entering into the jail requires stabilization through psychotropic medications. And we're able to do that with our on-site staff as well as the Stat Care program that Suzanne mentioned. We are connecting individuals to quality advanced psychiatry providers, advanced psychiatric nurse practitioners, as well as making routine visits with our patients within the facility to make sure that while they're with us, they remain safe and they remain stable. Beyond that, we're also looking to the next step and looking to those people who will be discharging back into the community. We have a weekly collaborative partnership meeting where we talk to community stakeholders and try to connect individuals to services and prepare for reentry and successful transition back to the community. We also have a weekly meeting within the facility to identify those who are high risk and high needs and make sure that we're managing their care appropriately. We've also been involved in the larger county's efforts at their Stepping Up initiative. And really what we're looking at is a diversion model, being able to divert people away from the criminal justice system when possible, and how we can coordinate care and move them through the system in the hopes of reducing recidivism in the long run. So we do a lot of initial triaging, acute care, and then we also proactively plan for those next steps so that people can safely reenter your community.
We're jumping around a little bit. I apologize. So going to the medication assisted treatment program. So that's a program that, is really so important. We've worked very hard to develop MAP programs in almost all of our facilities across the nation. And here at Mendocino, it's really kind of a three-pronged approach. So we want to first continue patients who are already on a medication-assisted treatment in the community. We want to continue those patients in their treatment once they enter the facility. And we have done that successfully. At times, we also want to initiate treatment for patients who come in addicted to opiates. And so we've had success as well initiating treatment in the appropriate patients who could really benefit from that. And then third, we want to make sure when patients are discharged that they receive a warm handoff to the community so that they can continue to receive the treatments that they need. So once we start them on a treatment, we certainly want to make sure they can continue that in the community and continue to be successful and free from addiction. So we've worked very closely with the Sheriff's Office and with the community agencies to develop a program where as the patients leave the facility, they receive that warm handoff straight to a community provider who can continue them on, buprenorphine or methadone to make sure that they are successful. We've written over 100 MAP prescriptions since the program launched in June of 2021 and have really developed this program at no extra charge to the county or sheriff's office. And I'll flip it back to Dr. Simpler.
Thank you. So this program that we are really proud to be a part of, back in 2010, before the advent of jail-based restoration programs in California, the average length of stay for individuals with severe mental illness to navigate the stages of criminal prosecution was almost 800 days, compared to 42 days for those individuals who did not have severe mental illness. And what we saw was an increase of people in Mendocino County waiting to transfer to the state hospital for competency restoration services. And for those of you who may not be familiar with that concept, basically individuals have a right to defend themselves in this process. And if someone is suffering from mental illness and they can't assist their attorney or they don't understand their legal situation, everything stops. And while individuals were waiting for we saw the numbers growing, that length of stay in jail without treatment increasing. In 2019, we successfully partnered with the Department of State Hospitals to launch a jail-based competency restoration program. And to date, we've seen 45 individuals matriculate through our program. 89% of those individuals were able to bypass the state hospital altogether, meaning that they did not have to transfer to Napa or another facility within the state. 11% of those individuals did go on to go to the hospital and were returned to us successfully, and we've maintained them without relapse, meaning that they could move forward in their legal case. And of that 89% that did not have to go to the state hospital, 78% of them were restored to competency, meaning that their mental illness was successfully treated to the point that they could understand their legal situation and they could assist their defense counsel. This is slightly higher than the national average of 70% of people who are restored at a state hospital. So we're quite proud of the services that we bring through our jail-based competency treatment and helping individuals navigate the stages of criminal prosecution much more quickly.
And last but not least, one of the other programs that we were able to implement, again with collaboration from the Sheriff's Office team, is a program to make sure we save anyone from overdose who may, encounter drugs in the jail, which unfortunately does still happen. So since we started this program of using Narcan in the jail, we've saved 22 patients from overdose. And these are patients that, we call that scenario man down. But when a patient, does come into contact with the substance, and then we are able to intervene with Narcan and resuscitate them. We are very fortunate and maybe knock on wood that we've had 0 deaths by overdose while in custody and 0 deaths by suicide while in custody during our time at your facility. Most recently, we just had a suicide attempt that we were able to quickly intervene and prevent that from being a completed suicide as well. So we very much appreciate the collaborative effort and the successes we've been able to achieve together during our time there. I think that is the conclusion of our PowerPoint. So we'll flip it back to Brad.
We just love to answer any questions if there's anything we can clarify for you.
All right, Supervisor Williams.
Yeah, can you show us any data comparing outcomes of your work versus other counties, the region, or state?
I don't know how we would.
So what I'm getting at is, if you were providing surgery, it would be interesting to know you've done 200 surgeries, but more interesting is how many of those patients died, right? How do these slides touch on what you do for us, but fall short of showing us the quality of the work or the outcomes. Is that something that you study?
Well, I don't know, how we could compare our services to, other jails where we don't necessarily have data on what they're doing. So
do you provide these services in other regions?
We do. We operate in 30 states across the country, and we have 90 contracts across our different lines of business.
So I think one way we could answer that is, we do certainly do quality assurance studies. So we do have a team that looks at our statistics across the board for all of our facilities. And we look at things like number of offsite trips, number of inpatient days in the hospital. We do look at, morbidity and mortality and study all of those factors in order to always improve our best practices. Does that kind of?
Yeah, is that something you could show us?
I don't have those statistics readily available to be able to show you, but we certainly can provide you.
Yeah, I would appreciate that. Frankly, when this was on consent, that's what I asked for, and I was expecting we would get a presentation of that today. You said you work closely with partners. Does that include our county's behavioral health department?
So yes, they meet weekly with, there's a discharge planner that is with the county, my understanding, and they meet with custody officers and NAFCARE to coordinate aftercare services for individuals. We would not necessarily be responsible for providing those services in the community, but we certainly make those connections and links to establish continuity of care and be able to provide medications and links to appointments, et cetera.
Got it. And Dr. Miller, are you able to describe that relationship and how it's working?
I can say that they do attend the weekly Monday morning, which is a group of crisis behavioral health and then jail and NAFCARE. I have heard that meeting goes very well, that it is a collaborative effort. And it is working to get people connected and sort of to services on the outside and making sure the discharge planner is able to know who's coming up for discharges and working to get them connected. Dr. Simpler also does attend our Stepping Up meeting, and I had reached out to NAFCARE because they weren't at Stepping Up, and I do want to acknowledge that they did come to the table. Amber has been there regularly, and they have provided some data for us in regards to Stepping Up as we've requested. So they have been willing to participate in community meetings as we have asked them to.
So Dr. Miller, you can endorse this item as written.
I don't know NAFCARE's contract and inside and out, so I wouldn't say that I can endorse it in that I know their work. That wouldn't be fair because I don't know. I don't work with them day to day. I'm not in custody. I'm not seeing their work. I don't see their mental health work. But from my experience with them, they have been willing to come to the table, speak outside. What we do from our end of things, we do audits and quality of assurance reviews before we can say we would endorse a contract. That's pretty regular in my role from behavioral health. It's what the state does to us.
Yeah.
I've never seen their stuff. So I wouldn't say I have a problem with NAFCARE is what I would say. they've been willing to come to the table and work with us when we've needed. They provided data as we needed, but I can't say I know the level of care because I'm not in their world and I'm not working with them on a daily basis. But I know they're willing to
Understood.
partner.
So I feel awkward asking the contractor to provide that. It seems like it's our job to somehow evaluate on this is $3.5 million on a $19 million contract, substantial. I'd like some assurance. I'm not a good judge of it. I have no idea what the quality. Who has the role in our organization of determining whether the service provided meets our standards?
So I'm going to say that's the sheriff's office. I did talk to Under Sheriff Brewster, and they do oversee this contract. It's within their budget. So both the sheriff's office and the jail, I think John Bedner has worked with NAFCARE closely. Sorry, John, but that's my understanding. And so I think that they would have the best information and the best people to endorse the services that are going on in the jail and the level of care that NAFCARE is providing.
Got it. So I look forward to a written report documenting the quality and outcomes and why we're content on spending another 3.5. I don't dispute it. I just don't know. This is an awfully thin item for a total of $19 million. I can't make heads or tails of it. And then last, I want to ask, given the size of the contract, do any Mendocino County employees work for NAFCARE or have any been transferred from the county to NAFCARE? I guess it's for NAFCARE or for county HR.
Sure. So Captain Pierce does now work for NAFCARE.
So would Captain Pierce, was the jail captain overseeing the jail, would have been involved in putting this contract together, has now left the county and works for you as a contractor, and you're asking for 3.5 million. You see the optics on this. The public is watching this, wondering what's going on.
We were very cautious in how we proceeded. Tim Pierce was very cautious in recusing himself. We were very mindful once we offered him a job to come work for us that we avoided any kind of conflict of interest. I certainly understand that concern. The reality is we wanted a leader who could lead our Las Vegas office. We had a good leader. He decided to run for sheriff there in Clark County. We were looking for someone to fill that very important role. We really believe in Tim Pierce as someone who could contribute to us, and he came to work for us.
And Supervisor, if I may speak on that, Captain Pierce was here, was recused. He had nothing to do with this contract, with this extension of this contract, and it was completely run through Sheriff Kendall with NAFCARE.
Okay, Supervisor McGordy.
So I would, this is kind of a joint question really for both Under Sheriff Brewster and Janine Miller. So the Stepping Up program is mentioned here. How is that going in implementation, and what's your assessment so far of its success and what needs to happen next?
I think I'll take that, Darren, unless you want to. So Stepping Up is a group of a variety of collaboratives. The Sheriff's Office, the jail, and NAFCARE are part of that executive team of Stepping Up, which does include behavioral health and a couple other community members, DA, public defender. I would say we've had a slow start. The biggest struggle for Mendocino County is data. We've struggled with having a universal data system that all the different departments, community providers can really track individuals in. Part of that is due to not having a system that talks. So interoperability has not been a really good option. It's very common, not an option in electronic health records. But then we've also struggled with HIPAA, CFR 42, and mental health laws and confidentiality for California. So we've had a variety of things that have really impacted our ability to get to a level where we are able to share information and really track. We have developed some pieces to move forward. We have worked with the state on how do we come up with a data system that can be used throughout Mendocino County and allow that. I do want to note that NAFCARE did come to the table. Amber and her group worked to say, hey, NAFCARE may have a system that could do this for you. So NAFCARE did bring some ideas and opportunities to the table for stepping up. And that was much appreciative and gave us more data than we've had. Our next steps, we really are looking at an RFA or an RFQ to find a data system, which is what was recommended by the state of California TAs, on next steps to really bring that data piece to Mendocino County. Without that data piece, we really can't track recidivism, and we need the ability to track recidivism, and we need to be able to track someone from when they go into custody, when they get out of custody, when they come into mental health care, when they end up back in probation, or when they end up back into custody, to really see if we have diversion programs in place that are really working to benefit the client. And until we have a data system that allows us to track one individual throughout that system of care, we will continue to be in the same space we are today, unable to really move forward. We are looking at diversion programs. We really are putting a map together of all mental health services and all services throughout the county to see what that flow looks like. But what we really need is that data system, and that's sort of our next step from stepping up.
Dr. Miller, maybe you could describe this. Has the funding for people who become inmates in the county jail changed in terms of their medical care? My understanding is that, at least in the past, if they were on Medicaid or some program, they'd be disenrolled in that government program once they were in the jail. Is that no longer the case? And can you just describe how that works?
I'm sure. No, that is still the case. There is some movement at the state through Cal Ames to make some changes in inmate Medi-Cal services, but we're looking at 2 or 3 years down the line. As of today, while your Medi-Cal doesn't turn off completely, it turns off while you're in custody. So what's changed is how it kind of goes up and it's turned off, but you don't get completely disconnected for so many days, depending on how long you are in. And it's a little quicker to get their Medi-Cal restarted on their way out, which is why when we put the discharge planner in the jail was to work on making sure people that need to get reconnected can and get connected to mental health and SUDT services. So we're still in that same problem, is that when they go into custody, their insurance doesn't provide insurance coverage. They lose their insurance coverage, and then it really is on the jail to provide those services. And we all know the cost of providing services has gone up, right? So we don't have funding for it, and the cost to be able to provide services has increased every year over the last few years.
Follow, if someone was under house arrest and they were not in the jail, would their Medicaid be taken away?
No. It's specifically, so what happens similar to the jail is what they call the IMD exclusion for mental health facilities, right? So it's a federal exclusion, and it's just, so what happens is it's an exclusion. It's only while you're an inmate. So if somebody is released on their own recognizance, they still have a court case pending, they're on home arrest, whatever, their Medi-Cal, their private insurance, that will still pay for their services. The moment you're within custody, that changes. And it's just something, unfortunately, the state and the feds, that's what's in place. There were some counties several years ago who could opt into a program within their jails to change how that funding happened. But my understanding was there was a requirement for counties to put so much up front to make that happen. In Mendocino County, we're still in that where when you go into custody, and most counties are in the state of California, you don't have insurance. Your insurance sort of disappears until you're released again.
Thanks for the background. Supervisor Hashak?
Thank you, Chair Judy. So with the contract for NAFCARE, is there a doctor or a nurse on duty 24/7, or what's that look like? And then the other question would be, what part does NAFCARE have for these patients who come in who have a mental illness, and do they recommend the treatment, how the person is hospital or how the person is jailed, I mean, and what kind of services they get while they're in jail?
So we do have 24/7 nursing. I'll start the answer, and then Suzanne Moore can probably speak with more granular detail to the particulars. And then one of the things we do at NAFCARE is The NCCHC, National Commission on Correctional Healthcare Standards, require a history and physical examination to be done within 14 days. We like to do that right up front. So our philosophy of care is to provide as much care up front, really try to identify, diagnose, and treat as much as we can with our patient population. So when they come in the jail, there's always a registered nurse who can do an intake screening, history and physical examination, identify our patient's needs. We have a lot of tools at our disposal to help us intervene quickly. One of the tools that Suzanne covered in her presentation was SureScripts, where we have our own software. We're also a software company, so we've designed an electronic health record for the correctional environment. And if I have your name and your zip code through SureScripts, we can quickly identify what medications you're on, what doses, and start those medications right away. So, everything that we do is really designed to allow us to quickly identify and treat the needs of our patient population to stabilize them. And that includes addressing their mental health needs. Dr. Simpler has been very instrumental in improving our systems to use the Columbia Suicide Scale and be more effective at identifying patients who are at risk of self-harm, at risk of potentially trying to take their lives, identify and make sure that we're keeping a close eye together with our custody partners on that patient population. You asked about doctor coverage. We have, Suzanne can probably speak better than I can, or Under Sheriff or Lieutenant Bednar, to the day-to-day operation, but we have medical providers who are working typically during the typical working hours and after hours. That's why that stack care service is so important. So we have 24/7 nurse practitioners that when that booking nurse has a patient in front of him or her who has high blood pressure or some needs medication started, that the booking nurse can interact in real time through our software, through the phone, whatever means, and a California licensed nurse practitioner can start that medication. So you always 24/7 have a medical provider, if not boots on the ground, available immediately. And that's just a unique service that we've created that doesn't exist anywhere else in correctional medicine. So that's just kind of an overview of how we work to intervene quickly and meet the needs of our patients, both from a medical and mental health standpoint. Supervisor Hashtag,
thank you.
Responsive.
Yeah. So does NAFCARE also get involved with ongoing, if a patient with a mental illness is going to be in for several months or longer, then they say, okay, this is the program this person needs to be under, not just the medicine, but also the recreation and all that, time outside of cell, all that, those issues that are involved with jail treatment.
Dr. Simpler, could you tackle that? You're better able than I am.
Certainly can. We can. And I think that there's been some discussion. I know Dr. Miller and I have talked about this previously about the extent of services in terms of mental health that NAFCARE can offer. We typically put mental health professionals, licensed social workers, individuals who are skilled and that is within their wheelhouse to provide those services within the jail. It's my understanding that when the contract started, that the county opted to put psychiatric nurses in those roles. And so we have to operate within their scope. We've talked about partnering with community agencies for an in-reach. So as I started earlier, our goal was really to stabilize individuals and to start them on medication. When people come into the jail, oftentimes they are not psychiatrically stable. There's really no way that they could participate in any kind of adjunctive therapy simply because of the level of disconnect, oftentimes with reality, because of the instability of their mental health. So our first and foremost goal is really to stabilize those psychiatric symptoms and when possible, connect them to services. That looks like medication for a lot of individuals. In terms of classification, that is not within our scope. Those decisions to keep a facility safe and secure, who gets out of their cell when, is really a decision that's made by custody. That is not our purview. Our job is to provide medical and mental health care. We partner with the sheriff's office and his staff and to make those decisions, but by and large, custody and classification is in charge of some of that. Most.
Okay, thank you.
Supervisor Williams and Supervisor McGordy.
Dr. Miller, based on the information attached to this item, if you were the decision maker, would you approve this contract?
That's a really hard question.
Or would you ask for more? And if you would ask for more, what would that more be?
If I was, so Dr. Simpler did speak about the fact that we have spoken at times about mental health services in custody. And I did do some research around the state of California, and I know Dr. Simpler had given me some data on what their cost would be, in addition to some information about other services they provide throughout the different areas that they provide services, so different states and stuff. One of the things that was clear in my research throughout the state is that one of the things you see in other counties is that they have a mental health clinician that assesses everyone that walks in the door with the nurse. So it's just not a nurse doing the assessment. If someone comes in and there's a thought that this person needs a mental health on any level, they have a clinician on staff doing a mental health assessment. And you'll see that through most of the larger, medium to larger counties, and even in some of the small rural counties. So what we know, and from my conversations with Dr. Simpler, we don't have a clinician in Mendocino County Jail. That was not part of their original contract, because that is something I asked. How did we go without getting at least one mental health clinician within that contract? They said that that is what was originally asked for. So if I was looking at doing something different with the NAFCARE contract, and whether it's NAFCARE provides it or the county has another contractor, I think it's easy to do through NAFCARE. I know that their cost, and of course, this was in April that we talked, so that cost could have changed, but we're looking at an additional anywhere from 160 to 350,000 to add 1 to 2 clinicians. But I think it is something that's missing. So if you were to ask me, Supervisor William, what is missing, we don't have a mental health clinician within our county jail. When you look at other county jails, what they find to be the most successful is they have a clinician doing assessments, and they're actually getting people diagnosed and starting on treatment because there's actually a clinician doing that piece. It's a piece that's missing that I think within the system of care. I know NAFCARE isn't coming and asking for more, but I do feel if we were really looking at what's needed, we're missing a mental health clinician. And whether the board decides to work with the sheriff's office and have that be individual NAFCARE provides and it's part of their treatment team, or does it a different way, that's up to the board and the sheriff's office. But that is a piece that I would advocate for if this was my contract.
And the success of the contract to date, do you think there's enough attached for us to make a determination?
I can't answer that. I don't know their services inside and out. So it's really hard for me to evaluate their contract because I don't work with them day to day.
Okay, Supervisor McGordy.
Are you fully staffed? Do you have everybody you need, and or are there vacancies in your program right now?
You're asking for NAFCARE, Supervisor? Yes, sir. So we do have a couple of RN positions open right now. It's been very difficult to staff RNs lately. The hospitals are paying extremely high amounts of money currently. We have, however, been able to cover those shifts with PRN nursing care. And so I don't think there's been any lapse in patient care coverage or coverage of the nurses, but we are looking to permanently fill a couple of RN positions. Yes, sir.
Just as a follow-up to that, if the contract allows people with reduced qualifications to fill in those slots, is there a commensurate decrease in the payment from the county?
No, sir, we don't allow lesser licensed people to fill in. We just allow temporary RNs versus a permanent RN. So they're exactly the same qualifications, and they're cleared by the facility and backgrounded, and they go through all of the same license verifications and checks that our permanent employees do.
I'm not seeing any additional questions at this time. Do we have any public comment on this agenda item?
There's no public comment on this item.
Dr. Miller, is this service something that the Behavioral Health Board ever discusses at the behavioral health meetings?
I would say there's been discussions. As this is a sheriff contract, it's not under behavioral health, so it's not a contract they've reviewed in depth. I know that they have done jail tours across the years. I think they have met with NAFCARE once or twice. We do have a behavioral health board member on the Stepping Up committee, and so they do participate in that. But I don't know that they've had an in-depth look at their contract and their services.
So would it be appropriate if we ask the Behavioral Health Board to look at this service prior to the contract coming up to the board for reconsideration in a year?
Yes, we could add that to their agenda, and they do overview all mental health services in the county, so it's not outside their scope.
Supervisor Williams?
Yeah, I don't want to provide a gap in services, but this isn't enough of a presentation for me for $19 million and a $3.5 million increase. It's just too thin, and I don't know what to do with it. If I were a contractor putting this together, I would show some outcomes. I'd have some more credible data. I'd probably be working with our director of behavioral health. I would just come in with more. This is just awfully thin. It's kind of like buying a car sight unseen. We don't even know what model it is or how many miles. I got nothing to go on. And it may be that there's county staff who do have that information. I don't have it, and I'm the decision maker. So I'm not against renewal, but I couldn't support it without supporting documentation.
Supervisor Williams, I'm a little confused by the 19 million. Our contract is just under 3.5 per year. Are you aggregating over a multi-year period?
Well, I was looking at the agenda item. I mean, so many millions of dollars in, I would think there'd be something to show by now. I mean, the slides kind of strike me as a glossy brochure, and I'm looking for outcomes. This has been a multi-year endeavor. How successful is it? If I were a contractor, I'd be comparing it to another county where I provide services, or even better, another county where a different contractor provides services to show this is what's working, this isn't. Maybe there's some opportunity for the county to augment and pay for additional services like Dr. Miller highlighted. We're falling short, not having a specialist that really should be part of the team. So I'm not critical of the service, but there's just not enough here to make a solid decision. The public is watching me wondering, $3.5 million, what are you going on?
Sure, I hear your concerns loud and clear, and certainly because we have our own electronic health record, because of our technology experience, we can provide data and information.
Why didn't you bring it? Why didn't you bring it or attach it? That's what I don't get.
Well, we believed that an overview of this level, showing what we had done was what you were looking for. I'm sorry if it wasn't everything you were expecting. We certainly can get you more information. I don't know how to give you that denominator. If you're looking to compare, I can show you what we do. Certainly, we could compare to other sites, but what other companies do, they don't share their data with us, and there isn't any kind of national database. One of the things that is really critical is we've been successful in saving lives. You haven't had deaths in your facility. We haven't had lawsuits and litigation that are very commonplace in our field. So, we really stand by our track record and our effectiveness in delivering the service.
So so I've had outreach from my constituents who say their family member has been in our jail solitary confinement for a period of months, out every other night, not seeing light of day, unmedicated. Why weren't they medicated? I don't know if that falls on us as a county or NAFCARE, but the first time I heard it, I thought that's not right. I've heard it N times now. And so it is a concern. And I think it's this board's responsibility to make sure we're taking care of our people, including our jail inmates. They are in our care. And, if that's a practice that happened in the past due to resources and it's been addressed, I'd sure like to see a trend line that it's no longer happening. And I mean, I guess I could ask how how many solitary confinements have to do with mental health, and what is the average duration in Mendocino County?
So I'm happy to address that question. And, you know, I've been on this call since, well, 11 o'clock my time, 9 o'clock your time this morning, and was very pleased to hear the discussion of the new facility. I'm not sure how many of you have actually been inside the county jail and seen the physical layout, but a lot of individuals aren't there because of their behavior in that solitary cell. It is the physical plant. That is how the cells are designed to some extent to have single cell placement. In terms of medication, we offer medication, but there are a lot of restrictions on to who we can compel to medication. So it's not that we're not offering treatment. It's not that we're not offering these services. We cannot do anything. We have to respect patient rights when they say, I'm not going to take this medication. And
even with a patient who's psychotic?
Yeah, that's how that goes. And we make steps. And in certain situations, we go through the steps to notify the courts. We get individuals who are involved in the jail-based competency restoration program. They will come attached with an involuntary medication order, but by and large, trying to involuntarily medicate someone outside of that competency framework takes a lot of steps. And we've been able to do that in some acute situations, but by and large, it's not something that the courts do easily, readily, or willingly.
Dr. Miller, is it your understanding that we have to wait for the court and that the holdup is really on the court, or are we not medicating all those who we could?
Based on what, and we've had a lot of conversations about forced medication within Mendocino County, both with Stepping Up has talked about it, even with our public defender DA and our judges. And we can't, at least in the state of California, or at least locally, we can't get around needing to have an incompetency to stand trial. So a 1368 needs to be declared. One of the issues we have in Mendocino County is that our individuals who do 1368s are usually psychologists or LCSWs or MFTs, not psychiatrists. And so when I did some research throughout the state of California, some counties can do a faster involuntary to medicate process because their individual that's making the determination for the 1368, which is when they determine that someone is incompetent to stand trial, is also able to, at that point, order a forced order to medicate. So in their report, they write up, yes, not only are they incompetent to stand trial, but they also need a forced order to medicate. In our system here, we do the 1368. It's not a qualified medical prescriber. We then have to go back and ask NAVCARE after the court order to go through the process to determine the forced order to medicate, and then go back to court to get that done. And so it is slowed in Mendocino County because of sort of the processes we have in place, and the professionals that we use don't allow us to fast track it as we see in other counties. I actually called several counties and talked because I was really perplexed on why we weren't able to fast track this quicker. They can do emergency medication in a safety situation, and they can talk about that. There are areas of the law that if it's a safety concern for the inmate or a correctional staff in that situation, they can medicate, but it's a one-time medication unless the person acts up again. So they can do forced medication in that situation. But if it's a long-term forced medication, it really does require that court order. And our system has a slower process.
What percent of our solitary confinements are mental health patients? Nobody knows.
I would have to look at we can certainly dive down and identify those single cases, but I could not do that right here on the spot.
And what is the average stay in solitary confinement for mental health patients? We don't know either. So there's just not enough data here. So I would like to move that we ask the sheriff, our behavioral health department, to work with the contractor to come back with a more substantial outcomes and evaluation of services.
One of the, through the chair, Under Sheriff Brewster, one of the things I could say is we have had an independent contractor for years that oversaw NAVCARE that was completely separated from NAVCARE and gave a direct report to the sheriff. The sheriff is extremely happy with what NAVCARE has done for this county, this jail, and the population within the walls of the jail. So we did have an independent contractor. She has since retired out, and we're looking for a new one to oversee, just to have an independent person that we trust to tell us, is NAVCare doing what they're supposed to be doing? When we had that person, the sheriff was extremely pleased with NAVCare on what they've done for our clientele. And like Brad had stated prior, the lack of lawsuits, deaths in the jail. It's extremely impressive if you look at other jails, what they go through, which is tough to do because every jail's either smaller, bigger. It's not the same setup. So when you're asking certain things, it's very hard to come up with that data because there's nothing like Mendocino. Mendocino's not like Humboldt. It's not like Lake. It's not like Sonoma. It's not like any other county. Mendocino is Mendocino County. So I just want it on the record that we have had that independent contractor that has overseen this contract.
What if the board authorized Dr. Miller to have her staff play the role that contractor previously played to get a timely evaluation and recommendation? She's our domain expert. This is her field.
Are you asking me if I have an issue with that?
Well, I guess, do you support it? And then for my colleagues, is that direction the board would support?
Through the board, I'll tell you that anything we could do to help our inmate population, the sheriff and I are in for. I know NAVCare is that way. I know Janine's that way. That is absolutely no issue at all for this office. We want to make sure that we give, and I think we do give, the best care we can for the facilities that we have and the money that we have associated with running this program. That we can do, and I stand fully behind it, and I know the sheriff does as well.
Thanks. Supervisor Heshek.
Well, I think that was a great idea about Dr. Miller. If she's has the capacity to do that, it would be good for the county and the jail. I'm just trying to figure out about this issue about the intake and the medical or the mental evaluation at that point that Dr. Miller says that we should be doing under, the best practice. So how do we get that into the contract? How, because it seems like if we know what the best practice is, with the $3.5 million contract, we should be able to implement the best practice if it's only a difference of 160,000. So is there any comment on how we could get that into this contract?
From a NAVCare perspective, we are certainly happy to add staffing and services. So that's always a budgetary issue, but we're supportive, certainly supportive of partnering with Dr. Miller or anyone you want to designate to work with us to look at what we're doing in the facility and the care. If you have additional, you identified some specific areas where you want data and metrics, Supervisor Williams, if there are areas where you want more data or information, we're happy to provide that to you. We're also happy to, share the results of our NCCHC audit where we got facility accredited with the National Commission on Correctional Healthcare for the first time. Those audits occur every 3 years. We had an excellent audit. So there is more information we can provide. We potentially could overwhelm you with information. So just want to make sure that we're responsive to your needs. We'll partner with anyone you want to designate.
I would point at Dr. Miller as that person.
Okay.
Supervisor McGordy.
So first of all, I share some of Supervisor Williams' concerns about kind of just being a little bit of a light document. And under your exhibit B5, and it says extension of year 1 invoicing and payment, it has mental health personnel at $570,000, $865. What are we getting for that? And why isn't that including someone who does mental health assessments for intake?
I'm happy to speak to that. I believe the number you're looking at, and correct me if I am wrong, Dr. Simpler, but I believe that may be the JBCT funding. So it's for the psychiatrist, psychologist, competency trainer, and clerical staff to run the competency program. Certainly, we do have psych RN positions in the matrix currently, and I agree with Dr. Simpler. Early on, a couple of years ago, we did have conversations with the independent contract monitor, and we really, discussed the importance of having, a behavioral health person, like an LCSW person on the matrix to really provide, that different type of mental health clinical care. And we just, weren't successful in making that change from maybe a psych RN position to more of an LCSW type of role. So we are certainly open to that, and certainly open to any negotiations, to try to make that happen. And we agree with Dr. Miller that that could be a very good, addition to the program, or even potentially exchanging perhaps one of the psych RN positions out for an LCSW. We could look at it. Could that be feasible as well? And one other piece I did want to mention, Supervisor Williams, I hear what you're saying in terms of needing more statistics and data, and I wish we had realized a lot of times when we do these types of presentations, we're told to keep it very succinct, and so I think we erred on the side of caution there. But one of the things we also do is try to provide a year-end summary to the sheriff once a year that has a lot of statistics and data in terms of off-site trips and ER trips and, deaths or the lack thereof, hopefully, and all those types of things. So we can certainly go back and compile those documents and present them to the board as well. That's very easy to go back and gather that information.
So a document like that would be really helpful if you could also span multiple years. So for the term that NAVCARE has performed this and collected the data, that'd be great. So we could sort of track if there's any trends.
Absolutely. Yes, sir.
And I mean, I think just think about it through your eyes. If you were in my place and you saw this agenda item with 2017 documents and no supporting data, what would you do? Right? And that's what you want to answer is come forward with a proposal that you think you would vote on if you were the decision maker.
Well, respectfully, I don't really think that's very fair. I mean, we understood you wanted a broad overview. I didn't understand that you wanted this level of detail. Sometimes elected officials want a ton of data. Sometimes they want an overview. So, now we have that mandate, and so we'll meet it.
Sounds like just a miscommunication, and I look forward to working with you.
Thank you.
Okay. We asked for public comment and been told there's no public comment on this item. Would anyone like to make a motion?
I move we direct Dr. Miller to work with the sheriff to come back with data from the contractor that she can endorse, ready for board approval.
Supervisor Hashak?
And I could second that if we could add on the option of this, medical evaluation right at the time of intake.
The first degrees.
Psychiatric evaluation, not medical.
Right, that's what I meant, sorry. Yeah.
Clerk, are you able to read back the motion?
So just to clarify the motion, we have direction for Dr. Miller to work with the sheriff to come back with data from the contractor that she can endorse, ready for board approval, and the addition of the psychiatric evaluation option to the contract.
That works.
Agreed.
Okay, thank you. Can we have a roll call?
Supervisor McGordy?
Yes.
Supervisor Mulhern?
Yes.
Chair Jurdy?
Yes.
Supervisor Hashak?
Yes.
And Supervisor Williams.
Yes.
The motion carries unanimously.